Hi, thank you for joining me. I would like to share what I am passionate and inquisitive about, which is post-traumatic stress disorder in level 1 trauma patients. The reason I am passionate about PTSD is because I have experienced it firsthand and have learned that it is preventable and manageable for someone to lead a productive life. Trauma affects 1.5 to 2.5 million Americans each year. Out of this population, 1/4 are at risk for developing post-traumatic stress disorder. The American College of Surgeons Committee on Trauma recommends trauma centers incorporate PTSD screening and referrals for those who fit the criteria of being high risk for the development of PTSD. The 3 pictures I put on this slide are to demonstrate that trauma comes in all forms, and with the different forms of trauma, PTSD can be a high risk factor for all individuals and in different scenarios. The development of my PICO question starts with the population, which is civilian adults in level 1 trauma. I specifically excluded military, veterans, people associated with war, and refugee populations because there are established guidelines and screening for them through the Department of Veteran Affairs and the Department of Defense. The intervention that I would like to use is early screening for PTSD compared to usual care, with the outcome of seeing if there is an increase in follow-up care with their primary care provider for PTSD symptoms. My timeline is from admission to discharge and in 1 to 3 months post-discharge. The beginning of my literature search strategy started with multiple databases. However, once I started looking for information, I noticed there was a significant gap in knowledge, which resulted in me using PubMed, CINAHL, PsycInfo, National Center for PTSD, and PTSD pubs. My planned approach to finding PTSD relevant research articles was by identifying important concepts, choosing appropriate keywords, identifying subject headings, incorporating Boolean operators, using limitations and advanced filters. As an example, I have included 2 of my searches through PubMed. As you can see, I really needed to narrow down my searches. Continuing on with my search, I applied filters such as publication dates from 2022 to 2024, humans, adults, ages 19 to 65 plus, English speaking. I included clinical studies, trials, comparative studies, controlled clinical trials, randomized controlled trials, so on and so forth, which resulted in 7,707 articles. I have attached a saved search through PubMed, which in the end result was 21 to 2 articles. Out of these 21 articles, I was able to pull 5 articles that looked promising in contributing to my research. The reason for my pictures in the next 5 slides is mandalas are thought to reduce stress and anxiety. So it's helping me, but it may also help you. This article focused on acute stress disorder within 72 hours. The study was from June to December 2020 in the Level 1 Trauma Unit at the University of Kansas Health System. They included adults ages 18 to 89, Exclusions were if they didn't want to participate, COVID-19, and non-English speaking. The study used an in-house screening tool called the KU Trauma Acute Stress Pathway Symptom Screening Tool. And if participants experienced 3 or more symptoms, they were followed up at 72 hours post-discharge and in 30 days to give education, resources, and instructions to follow up with their PCP. Compared to the 4 other articles, I included this article because it contributes to the need for early screening intervention in level 1 trauma patients. Patterns that I noticed was the emphasis that participants were very proactive in their care and supported that there is a gap in knowledge in early intervention screening. The second article that I used is Engaging and Following Physical Injury Survivors at Risk for Developing Post-Traumatic Stress Disorder Symptoms, a 25-site U.S. national study. The random controlled trial study focused on the impact of collaborating interventional care on people experiencing PTSD symptoms. The emphasis was on the use of technological innovation as a means of assisting in follow-up care. The study was at the University of Washington's Harborview Medical Center. Participants were in U.S. Level 1 trauma centers from January 2016 to November 2019. They were assessed at 3, 6, and 12 months. Exclusions were non-English speaking, prisoners, and self-inflicted injury. They found there is a correlation between having no cell phone or internet access contributing to the lack of follow-up attainment and treatment. This is important because early screening intervention for PTSD needs to be able to reach all people in all socioeconomic demographics. It also highlights a limitation in future studies that not all people are going to have internet access or the use of a cell phone or know how to use technological devices, which I feel like I need to take into consideration in my own studies. Article 3, Feasibility of Risk Factor-Based Screening for Post-Traumatic Stress Disorder and Trauma, took a different approach and focused on people who they thought were more at risk in developing PTSD related to level 1 trauma. Criteria they used were social factors of unemployment, race, or ethnicity, and poverty. This study took place from December 2021 to March 2022. It consisted of 17 to 30-year-olds and were screened through the PCL-5 screening tool. Out of 200 participants, 1/6 met their criteria, with the end result being implementing a universal screening for all trauma patients versus focusing on a population who are identified at more at risk of developing PTSD. This is significant as it supports that everyone should be screened after a traumatic event. Study 4, Screening, Brief Intervention, and Referral to Treatment to Prevent Post-Traumatic Stress Disorder After Gunshot Wounds, was significant because it utilized multiple screening tools and assessments, and the end result was improved symptoms of PTSD. Limitations to their study included a small sample size, mostly men, specific to gunshot wounds, and was a short study period. But overall, it demonstrated a lack of PTSD screening and supported the need for one. The last article I chose was Stepped Collaborative Care for Pain and Post-Traumatic Stress Disorder After Major Trauma, a randomized controlled feasibility trial. This, along with Article 2, I felt were the most trustworthy sources and dependable pieces of information because they both passed the CASP checklist. This mixed method study was in Australia from November 2019 to September 2020. This study implemented a case manager to coordinate stepped care, which addressed physical, mental, and emotional needs such as medication management, cognitive behavioral therapy, psychoeducation, relaxation and grounding, and motivational interviewing. All participants had an increased willingness to be active participants in their care. Barriers were limitations to access of caseworkers, COVID-19 pandemic, and technology was a barrier, which coincides with Article 2. In the end, the study reinforced the need to address the mental and emotional part of trauma and not just the physical aspect of it. Recommendations of early PTSD screening can result in early detection, accessible screening tools, improved patient outcomes that results in appropriate resources, education, referrals, prevention of chronic PTSD, initiates early access to mental health support, reduces stigma surrounding PTSD, and opens a door for follow-up care. In conclusion, every article provided substantial evidence that supported the need for universal PTSD screening in Level 1 trauma patients. 2 studies mentioned the recommended protocol for PTSD screening by the American College of Surgeons Committee on Trauma. Through the articles, I learned that using a case manager is vital in coordinating holistic care for patients. Areas that I would like to implement in the future are the use of technology, a case manager, and collaboration of stepped care. Limitations and barriers that I need to keep in mind are the risk of small population sizes, lack of a longitudinal study, and a small representation of socio-demographics. However, the articles confirm that early screening, education, and holistic care are positively received by participants, reflect overall reduced PTSD symptoms, and the need for further investigation. These are my references. Thank you for allowing me to share my passion towards helping people identify and screen for PTSD in Level 1 trauma patients.